So again, welcome to today's presentation. This is going to be the third session in our Day 1 Organizational Wellbeing and Healthcare National Symposium. My name is David Terry, and I am the Program Manager for the Mountain Plains Mental Health Technology Transfer Center, serving HHS Region 8. And please do note that our session is being recorded and resources will be made available on our program website for later viewing. A brief disclaimer as we get started today. Today's presentation is available in the public domain and should not be distributed for a fee without the express written permission of the MHTTC network. And the views and opinions expressed during today's presentation are those of our presenters and do not reflect the official position of the Department of Health and Human Services or SAMHSA. No official support or endorsement of DHHS or SAMHSA is intended or should be inferred. As I've noted, all attendees are muted for today's session and all attendee videos are disabled. Please feel free to submit questions using the Q&A feature, as we will have time for Q&A at the end of today's session. And we will be having a Q&A hosted both for Dr. West and Dr. Peccoralo combined at the end of today's session. So again, please feel free to send those questions through in Q&A or in the chat box. Please note that depending on how you are using the chat box, your questions or responses can be seen by everyone in the session or just by the panelists and hosts. Slides and recordings for today's session can be accessed on our program website. And we will ask you to complete a brief survey at the end of today's session. We sincerely appreciate you taking the time to complete this survey, as it is the only thing SAMHSA requires from us in exchange for today's free training. Today's event is being closed captioned, and you will receive an email on how to access a certificate of attendance at the end of today's session, and you must attend at least half of the session in order to be eligible to receive a certificate of attendance. And we encourage you to follow us on social media. For those of you that might not already know a bit about our network, the MHTTC network has a focus on accelerating the adoption and implementation of mental health-related evidence-based practices across our nation. We have 10 regional centers, a National American Indian and Alaska Native Center, a National Hispanic and Latino Center, and a network coordinating office. These centers work to support one another, and today's symposium is a great example of how our network collaborates to engage in knowledge transfer. Here you can see a map of our centers. We encourage you to connect with your regional MHTTC, as we are a resource for the entire nation. And we are very excited to provide this symposium in support of the MHTTC Provider Wellbeing Initiative that focuses on advancing well-being and self-care in the health and behavioral health workforce. We have many available resources for you to access via our Provider Wellbeing Program websites. And you can look for more information on events and resources to support organizations and individuals in the coming months and the coming year. And just a brief overview so you know where we are in the progress on our symposium. We are moving into the final session for day 1. We really look forward to you joining us for tomorrow's sessions and our focus on knowledge translation and practice. And with all of that being said, thank you so much for joining us. I'm excited to move to the special topics in organizational well-being. We're going to start today's session with Dr. Colin West, and Dr. West will be providing us with a discussion on physician well-being and moving from burnout to thriving in modern medicine. Dr. West's presentation will be followed by a presentation by Dr. Lauren Peccoralo on creating organizational culture change to promote well-being and engagement strategies for leaders. And I am happy to welcome Dr. Colin West to today's session. Dr. Colin West, MD, PhD, is originally from Seattle, Washington, and received his MD and PhD from the University of Iowa. He completed his residency at Mayo Clinic and is a faculty member in general internal medicine at Mayo Clinic. He is currently a professor of medicine, medical education, and biostatistics at Mayo. And in addition to this work, Dr. West is co-director of the Mayo Clinic program on physician well-being and has focused his research on medical education and well-being practices. And I'm going to stop my share and welcome and turn things over to Dr. West.
All right, great. Thank you very much for the introduction and for the opportunity to be with all of you today. As mentioned, I'm going to talk about physician well-being, but really everything that I say will be relevant to other healthcare professionals as well. Our program has its origins in studies of physicians, but we have branched out in recent years, recognizing that this really is a profession-wide issue that speaks to our goal of providing great care to all of our patients. I have no disclosures. My contact information is here, both Twitter handle and email. Slides will be made available as David mentioned. So I'm going to move quickly through my content, make sure that we have time for all of the discussion points and Dr. Peccoralo's session as well. I won't read the learning objectives to you, but briefly, we're going to highlight the overview of the magnitude of distress issues in medicine. We'll talk about our common model of contributors to and understanding of consequences of this distress. And we'll talk about solutions with particular emphasis on organizational strategies and the role of leadership in improving our working environments. And of course, all of this has been challenged by the pandemic, which unfortunately continues to ebb and flow to various degrees as we worry about heading into yet another wave. When we talk about distress, one of the common areas that we consider is burnout. And burnout has a colloquial definition for most of us, but from a study standpoint, it has a very particular definition. It involves 3 domains that diminish effectiveness at work. These include depersonalization, emotional exhaustion, and a sense of low personal accomplishment. I won't say a whole lot more about sense of low personal accomplishment because that has not, in our work anyway, linked as strongly to key outcomes. But I will say a bit about emotional exhaustion and depersonalization. Emotional exhaustion is illustrated by this statement. I feel like I'm at the end of my rope. This means emotionally in your interactions in medicine with patients. Feeling like emotionally you have nothing left to give. This is not physical fatigue. This is not waking up in the morning with muscles aching. This is emotionally feeling like you're just husked out. Depersonalization is illustrated by this statement. I've become more callous toward people since I took this job. This involves a sense of treating other humans as objects rather than human beings, obviously antithetical to all of the professional ideals that we hold dear in medicine. These are measured on continuous scales, but if they're present at least weekly, that has been linked with substantial adverse consequences for healthcare professionals. And we'll come back to those consequences in a bit. When does this start, at least for physicians? Well, it turns out that research suggests that burnout and depressive symptoms, and in fact, every measured domain of quality of life, is better at the time of matriculation into medical school for medical students than their age-similar college graduates. So our medical students are starting their training actually in a pretty good place as a rule. By the end of the 2nd year of medical school, however, this has flipped, and their burnout and depressive symptoms are actually worse. Their quality of life is worse than their age-matched peers. So there is something about the learning and training environment and how that interacts with these individuals that promotes distress. Unfortunately, this continues through training and into practice. And we know from our national studies in partnership with the American Medical Association that overall burnout rates have hovered in the 45 to 55% level over the last 10 years or so. We see the breakdown here of emotional exhaustion and depersonalization subdomains as well. And I'll draw your attention to the depersonalization. 30% of our physicians across the country endorse becoming more callous or feeling more callous toward their patients at least weekly. That is not what we want from an interaction with our patients standpoint in support of our healthcare system. And we'll talk more about where we need to develop our solutions to support these clinicians rather than blaming them as individuals for not meeting their own internal aspirations. It's not all just about burnout, though. Physicians are also commonly dissatisfied with their work-life balance, and rates of positive depression screens are quite high among physicians. Now, these are screening rates. This does not mean that 40% of physicians have depression, but a quarter to a third of these who screen positive would be diagnosable with depression if they went through a formal assessment. So the numbers are indeed concerning. We, in the past, often received questions about, well, everyone's stressed in society. So, physicians and other healthcare professionals actually commonly have job security, respect, esteem in society. So maybe they're actually protected from that position of privilege. So what does it look like everywhere else? Maybe it's going on in physicians, but is this really as important an issue? And unfortunately, it turns out that for physicians in particular, they have higher rates of burnout and higher rates of dissatisfaction with work-life integration than others in the employed US population. We also know from literature that I have not cited here that suicidal ideation and suicide rates among other healthcare professionals, especially nurses, are markedly higher than rates in the general population. The rate among nurses may be even double the general population rate. So there are serious well-being and mental health concerns among our healthcare professionals. I've hinted at this already from a mental health standpoint, but there are many consequences of physician burnout and by extension, burnout and distress among other healthcare professionals, really relevant to every stakeholder in our healthcare system. So for patients, medical errors are increased, professionalism is decreased, patient satisfaction can be reduced, and there's even suggestion that racial bias in patient care can be associated with physician burnout. From an access standpoint, staff turnover and reduced clinical hours are associated with burnout. Physicians will turn to switching jobs or reducing their clinical effort in an effort to cope with the distress that they're feeling. That is difficult from an access standpoint for our patients, and it's financially very expensive to our healthcare system. And then from an individual and public health standpoint, blunted growth in medical knowledge, the mental health issues I've already mentioned, and even public safety around motor vehicle crashes and near misses. After adjusting for fatigue, physician burnout is associated with subsequent increased risk of these motor vehicle incidents. When we just look at physicians and just look at burnout and its associations with job turnover, burnout costs us nearly $5 billion a year from an economics analysis conducted in partnership with the Harvard Business School. So the total costs of physician burnout are many times this when we think about extending this to other consequences beyond job turnover and other job categories beyond physicians. When we look at the prevalence in total, we have more than 40,000 medical students, 60,000 residents and fellows, and 490,000 physicians struggling with burnout on a regular basis. When we add in all of the other healthcare and biomedical science professionals, for example, we have 3.5 million nurses in the United States. Burnout studies nationally suggest their rates around 35%. So if we have more than 1 million nurses dealing with burnout, to add to all of these numbers on the slide, we're dealing with a really quite massive public health crisis. Those numbers also serve to make this a rhetorical question. Is this a problem rooted in our individuals and their failings or deficiencies, or is this grounded in a system that does not allow people to flourish and thrive? And the system is where the solutions need to be. Fortunately, we do have a bit of a guidebook for how to address these kinds of system issues, and even a bit of an historical marker as well. So when we think about patient safety, it's a little bit hard to believe now, but until 1999, when To Err is Human came out, the most common approach to errors was to blame the individuals and figure out how they could have performed better. Morbidity and mortality rounds were commonly about holding up the individual to figure out where they needed to function better. To err as human turned this on its head and said, wait a minute, we've got well-meaning, highly trained individuals who are still involved in errors. That means the system is not supporting them adequately. And in the Deming tradition, Paul Batalden has been quoted as saying, every system is perfectly designed to get the results it gets. So when we think about burnout and we think about distress in healthcare, we need to look in the mirror and say, wait a minute, our system is delivering what we have designed it to deliver. We need to change the design. One way to inform this from a 30,000-foot view is to think about models for distress. And the job demands resources model is one of the simplest but most compelling models. And in this model, a chronic imbalance of high job demands and inadequate job resources can lead to burnout. Really very simple. But in medicine, most of our job demands are actually high level. So we need high levels of job resources simultaneously to allow us to be able to cope with those demands. If our resources fall short, the demands do not change and distress results. So we need to think about systemically, organizationally, how do we match resources to the demands of our medical work roles so that we can promote engagement, thriving, and flourishing as opposed to distress. Another way of thinking about this is to think about where we are on our performance curves. On the left here is the Yerkes-Dodson law, which posits that, especially for difficult tasks, if the level of arousal or stimulation or stress gets too high, performance begins to suffer. Now, we recognize that a certain amount of stress promotes growth. And in fact, many in healthcare thrive under these levels of manageable stress. But it's less commonly recognized that when that stress becomes too much, when it shifts into chronic exhaustion, that's actually hindering performance. We do not level off or plateau. We actually decline in our performance. This is similar to the Starling curve for sarcomeres and cardiac performance. And for humans on the right in the stress response curve, again, we see that performance suffers when we move out of this optimal zone of performance and into exhaustion, ill health, burnout, and breakdown. So to optimize our performance, we need to be intentional about shifting our place on this curve. What kind of dimensions can inform strategies to promote the more positive aspects of work performance then? And so a model that we have used, which aligns well with other models from Stanford and from the National Academy of Medicine, orients around this honeycomb of driver dimensions. Workload and job demands are important. Control input at work is important. Social support and community, efficiency, resources to do your job, organizational culture, all important. And at the center of this is meaning in work, what I call the MVPs of well-being, meaning, values, and purpose. These drivers can inform where our organizational solutions should be to push people toward that more optimal work performance. I'll give you one quick example to suggest how out of alignment we are in terms of work efficiency. We think about documentation regulations. The length of US notes versus the length of notes in other countries has been studied for ambulatory conditions. In this study from Downing and colleagues, published in Annals of Internal Medicine in 2018. And what they found here in the lighter shade, you see all of the notes from US clinics, the average lengths from various US clinics for ambulatory conditions. You see in the darker shade on the left side of the screen, the average note length for international clinics that were similar in structure and we're seeing similar diagnoses. What you notice is that the average note length is markedly longer, 3 or 4 times longer in the United States. You also see that the clinic internationally that had the longest average note length still had shorter notes than the US clinic with the shortest average note lengths. No overlap whatsoever. Now, this might make sense. Maybe we could justify this if we had outcomes in the United States for ambulatory conditions that were better than outcomes for similar presentations internationally. But we know that's not true. When we look at our outcome data for system performance, we actually don't do as well in the United States, and we're certainly not as cost effective. We provide less value for our management of common ambulatory conditions. So who is benefiting if our patients and our physicians are not from these long documents? And is that acceptable? Or is that an opportunity to increase our physicians and other healthcare professionals' abilities to focus on what gives them meaning, values, and purpose, their direct time with patients, and less on the clerical burdens or what Mark Linzer has described as the hassle factors of medical practice? Now, I've hinted strongly at the need for system and organization level solutions. That doesn't absolve us from individual responsibility, and there are individual strategies that matter. Identifying values and aligning your practice with those values is important, and it should be intentional. Taking care of ourselves is important. We need to calibrate our distress levels. We need to get the right amounts of sleep. We need to exercise. We need to have healthy diets, look for positive relationships, pursue our personal interests. These will look different for every individual. They remain important. To recognize distress, there are tools out there that can allow people to confidentially self-evaluate. This is important because we're really bad at this in medicine. Although sometimes we view ourselves as complaining about our environment, it turns out that when we're asked about how we're doing on instruments, we will overrate. If we're asked without using validated instruments, we will overrate our well-being commonly. These online tools provide a more accurate assessment so that we can self-assess. The web link in the middle of the slide will be available when the slides are available. This is available for individual use free of charge. I'm not associated with this index, so I have no conflicts here. And again, it's free of charge for individual use, but provides a dashboard of feedback around well-being dimensions. There are also depression awareness and suicide prevention tools, and the American Medical Association has a number of modules that are both helpful for individual mental health support and also individual strategies to increase efficiency in clinical practice. There is, however, a risk of an exclusively individual focus, and that is that this can deepen cynicism by sending the message that we as individuals need to simply get tougher in dealing with our working environment, rather than addressing the working environment itself. And it's a very short walk from this kind of a mentality to feeling like we're blaming the victims. And that, given that we're dealing with a system-driven issue, really is something that we need to move beyond. To further this, we recently studied, came out about a year ago, resilience among physicians compared to the general US working population. And it turns out, to the surprise of absolutely no physician anywhere, that physicians have higher resilience levels than the general population, despite having markedly higher burnout levels. So our physicians, and I dare say our other healthcare professionals who have gone through rigorous training to be the experts that they are in their fields, already bring a tremendous amount of resilience and grit to their work environment. So to tell them that the only thing to do is to get tougher is really a slap in the face to them. We see from this slide, focusing on the right with overall burnout, that resilience is helpful, however. Higher resilience scores are associated with lower burnout rates. However, 30% of those with even the highest possible resilience score still had meaningful degrees of burnout symptoms. So resilience is not enough all by itself. Physicians don't have a resilience deficit overall. This means resilience is important. We need to maintain it and even strengthen it where we can. These individual maintenance strategies do remain relevant, but these individual solutions cannot be the mainstays in our approaches to promote well-being and thriving, because even the most resilient among us remain at substantial risk of burnout. So again, I'm a broken record. Organizational approaches to improve the working and learning environments are mandatory. So let's turn to organizations. 30,000 foot view. What can organizations do? Well, values are crucial. Organizations should promote the values of the medical profession, and there needs to be alignment between those values and the lived expectations and experiences of our healthcare employees. Organizations need to ensure adequate resources to meet the resources part of that job demands resource equation. Autonomy, input, a sense of control is important, and honoring the fact that our healthcare professionals are humans and need to integrate their work and home roles is crucial. And of course, underlying all of this, organizations should seek to connect their employees with meaning, values, and purpose. We've outlined at Mayo a number of organizational strategies. I wish to emphasize that these are aspirational. We do not have this figured out at Mayo Clinic. We're still working toward an optimal work environment. But these are the strategies that we put forward as important to push us forward. Acknowledging and assessing the problem. Can't deal with a problem that you refuse to acknowledge. I won't read the list to you, but you see here, community is important. Resources for self-care are important. And we need better understanding of the organizational science around culture change. One approach that I've used with work units is to ask individuals and leaders to fill out simple matrices, such as is illustrated on the slide here for you. Individual and organizational solutions across various dimensions or drivers of well-being or distress. So here we have 5 categories, and people could fill in, well, individually, what might be a solution to this problem? Organizational, what might be a solution to this problem? And this allows individuals to prioritize while they're brainstorming what the solutions might look like. This is an example. This is not meant to be a gold standard, but for an individual, they might identify going part-time as the best way for them to reduce their workload. From an organizational standpoint, workload could be addressed by revisiting productivity targets, reinvesting or highlighting the importance of things like duty hour requirements so that people can stay well in a sustainable manner rather than just running work sprints, so to speak. Medical career is a marathon. You cannot run a marathon at a sustained sprinter's pace. And integrating career development with well-being focus throughout a career. Skipping to the bottom from meaning and value standpoint, individually, positive psychology has been demonstrated to be helpful along with mindfulness approaches. This is not meant to be Pollyanna-ish, and we need to be careful about impressing what's been called toxic positivity on our healthcare employees. But building community can help people crowdsource solutions and feel more connected. Organizationally, how do we advocate for our core values, protect time with patients, promote community and positive work and learning climates as leadership focal points for which we are held accountable? I won't read this slide to you. It's not meant to be read in detail. The paper is linked. This is a very complicated summary that's meant to really just impress upon everyone that there are a wealth of potential solutions out there at every level for every driver category of burnout and engagement. This focuses on physicians, but a similar matrix can be developed for every other group of healthcare professionals. The solutions are out there. We need to prioritize them and figure out which ones make the most sense in our work units and our organizations, and we need to commit to implementing those solutions. Other categories of solutions have been outlined at various alphabet organizations as listed on the slide here. And I would say what's rising to the top in recent years has been the National Academy of Medicine effort. And so that link in particular may be worth taking a closer look at. As an example of organizational strategies promoted by the National Academy of Medicine, this paper on evidence-based and promising practices came out last fall. Not a lot of surprises here, if I'm honest. The big categories of focus for strategies involve demonstrated organizational commitment to your healthcare workforce, committing to assessing your workforce and responding to those assessments, leadership and leadership training, policies to promote well-being, investing in efficiency of the work environment, and consistently providing support to allow employees to thrive are key organizational strategies. And importantly, recognizing that resilience is not just an individual strength. We commonly think of it as, oh, you're telling me to be tougher or stronger. No, this is also an organizational characteristic, and we can invest and promote resilience at the organizational level. In my last couple of minutes, I want to highlight some leadership strategies that are relevant for organizations. We're all familiar with the triple aim from the IHI about improving the health of populations, patient experiences, and reducing costs. But we actually need to advance this to what's been called the quadruple aim, which adds that we can't meet these aims unless we improve the work lives of our healthcare professionals. This means that physician well-being is a quality marker, and it needs to be a core value. Healthcare professional well-being needs to be a core value of our organizations. It's not about how much this costs alone. It's, if this is a core value, we must invest in this because it's part of the fabric of who we are. That means we have to evaluate the impact of policies on well-being, not just traditional metrics. And we need to rethink how we define success. I was part of a team that developed the Charter on Physician Well-being. This lists guiding principles and key commitments to promote physician well-being, including that this is an integrated interprofessional phenomenon. It really extends beyond just physicians to our entire healthcare system. This is linked through the American Medical Association, and organizations can formally endorse the Charter as we continue to build momentum toward positive changes in our healthcare system. Again, if the solutions are built around these drivers, whether they're individual or organizational, then we can push our healthcare workforce toward engagement, flourishing, and thriving, and leave this era of distress and burnout behind. It takes work and commitment, but we've got groups around the country, including yours as evidenced by this symposium, who are rolling up their sleeves to tackle this. Happy to take comments and questions at the end of the session. My contact information is here. And with this, I will stop sharing and hand it over to David to introduce Dr. Peccoralo.
Great, thank you so much, Dr. West. Let me get my screen share back up here and then move us right along. So it is my pleasure to welcome Dr. Lauren Peccoralo to present on creating organizational culture change to promote well-being and engagement strategies for leaders. So Dr. Lauren Peccoralo, MD, MPH, is the Senior Associate Dean for Faculty Wellbeing and Development and is an Associate Professor in the Department of Medicine and Medical Education at the Icahn School of Medicine at Mount Sinai. Dr. Peccoralo has deep roots at the School of Medicine and completed her MPH and internal medicine residency and fellowship at Icahn School of Medicine, where she currently practices as a physician and medical educator. Dr. Peccoralo has developed a robust institution-wide faculty well-being program, a leadership workshop in appreciation, coaching, and leadership mentoring, as well as development, and focuses on reducing clerical burdens for physicians. And with that, it is my pleasure to turn things over to Dr. Peccoralo for her presentation.
Thank you so much, and just give me a minute to get my screen up. Okay, I hope you can all see my first slide. And thank you, Dr. West, for an excellent overview, and so many things were going through my head as you were talking. I wanted to say, yes, that's so true. So I hope that what I can do now is give a little bit of a deeper dive into the idea of what it means to be a leader promoting well-being within an institution. And so very briefly going to review some of the relationships between burnout, well-being, and leadership specifically. And then I'm going to talk about ways to operationalize well-being related leadership behaviors and some strategies that include things like coaching, communication, empowerment, and appreciation. So I think, as everybody knows, strong leadership can really change the culture of an institution, and in doing so, it can, affect the way teams are engaged. It can improve quality of care. It can improve productivity and patient satisfaction. It can even decrease turnover and increase performance. And so, what is strong leadership, and how do we actually get there? And so a number of our colleagues in the well-being and burnout worlds took a look at a leadership well-being index that they created, the Mayo Leadership Index. And they looked at these 9, there's also a 12-item version of leadership qualities or behaviors and their association with burnout. And so what I wanted to show you was this very strong relationship that was found, was that for every 1 point increase in the leadership index that teams rated their leader to be, there was a 9% increase in professional satisfaction associated and a 3.3% decrease in burnout. And I will tell you that we did this at our system as well, and we found the exact same results. So this is a replicable finding. There's such a strong relationship here. In addition, a number of other studies have looked at the relationships between leadership and professional satisfaction and mental health. And so it's been shown that workers who feel respected by their supervisors report 56% better health and well-being and 89% greater enjoyment and satisfaction with their jobs, and are more likely to stay. And in addition, we found in our recent COVID work that feeling valued and supported at work portends a lower risk of depression, anxiety, and PTSD during COVID. In addition, it's very clear that mentorship and professional coaching can decrease burnout and stress. And ratings of leaders specifically on providing feedback and coaching are independently associated with burnout. And then finally, this idea of appreciation, right? What does appreciation actually do other than just make someone feel good for a couple of seconds? Well, it actually does something. It can make people more productive. So for example, I'm sure many of you have heard of Adam Grant. He did a study that looked at college volunteers who were making phone calls. And basically those that were thanked directly generated 50% more phone calls and were significantly more likely to take on additional work. And in addition, we know that from the work from Mayo, that ratings of leaders on recognizing folks for a job well done is also independently associated with burnout. And so with all that in mind, I wanted to take us to these 5 core leadership skills. And these skills are, nothing, surprising, I don't think, but I think if what's helpful for me is to think about these skills and then think about how we can actually develop them. And so the first one is to include, right? Are leaders engaging and including all? Are they creating a safe environment for two-way communication? Are they inquiring? Are they asking for feedback? And are they really listening to that feedback? Are they informing? Are they being authentic? Are they providing transparent, frequent communication? Are they developing? Do all staff feel like they have a journey that they're on, a career journey? And does their leader actually feel invested in that? And then finally, does the leader express gratitude and appreciation? And so what I'm going to talk about for the rest of my section is just some approaches that we've taken at Mount Sinai to try to enhance all 5 of these core leadership skills for the leaders in our institution. So the first 2, we created workshops. The first one was Coaching for Growth workshop. And I'm going to go through just a little bit of the details of that workshop. And then the second one was a Leveling Up Praise and Appreciation workshop. So let's start with the first one. This is really focused on the inquire and develop skills for leaders. And so the 3 core skills here are asking, listening, and coaching for growth. I'm sure many of you have heard about humble inquiry, but if you haven't, I will just read out this definition. So humble inquiry is the skill and art of drawing someone out, of asking questions to which you do not already know the answer, of building a relationship based on curiosity and interest in the other person. So when I think about humble inquiry, I think, how well do I know the people that work with me, right? how often do I ask them about not only their, what they did over the weekend, but what are their goals? What are their passions? What do they really want to be doing with their work? How often do I really ask that versus just kind of getting the work done, right? So the reality is, by asking these questions, not only do you begin to know a person better, but you build a relationship, you build trust, and that other person is going to feel like you are someone they want to impress and be engaged with. The flip side of that is, once you ask the question, it's really your opportunity just to shut up and not talk anymore, right? And listening is really the most powerful form of acknowledgement. So it's your opportunity just to listen, maybe to ask some additional probing questions, but not to start talking and giving advice. And we show this slide because it's nice for folks to give a sense of what some humble inquiry questions might be. So some examples are: what work is most exciting to you? What are you passionate about? What motivates you? What is one thing that you learned recently that inspired you? It's also important in all of these conversations to think about your own biases. What are you bringing to the table? What assumptions are you bringing to the table about a person that's sitting in front of you? And to really try your best to kind of wash those away and be open to any kind of answer that you might get, and being surprised potentially with what you might learn. And then finally, obviously, it's important to listen actively, right? Make eye contact, say, I understand, that makes sense, and then reflecting back. And so these sort of 2 skills / 3 skills really bring us into this idea of coaching, right? And what is coaching? So coined by Sir John Whitmore, who was sort of the father of this idea of coaching. So coaching is unlocking a person's potential to maximize their own performance, helping them to learn rather than teaching them. And I like to think about coaching and mentoring as kind of this Venn diagram, where really extreme mentoring is like strictly on the advising side, right? Someone comes into you and they say, how do I get to my next step? And you kind of tell them every single thing that you think they need to do, right? Everything from what their goal should be to how they should get to their goal to the people they need to talk to. Coaching at the extreme end of coaching is simply asking the questions and not giving any answers, not giving any advice, simply asking and facilitating the coachee or the mentee to create their own path and find their own goals and create their own goals and find their own ways to get there. So obviously, there are very few relationships that are strictly advising or strictly coaching, but one of the things that we try to do in this workshop is try to get people a little more toward the coaching bubble. So using humble inquiry, using listening skills, and using the GROW model, which I'll review in just a second. And I just wanted to mention, again, nothing surprising here, but what are some of the benefits of having this type of a culture? First of all, there's often improved performance and productivity. Sometimes there's a little bit of upfront time that a leader might have to put in, but once their team members are sort of off and running, there's a lot less time that the leader has to put in. There's a lot of engagement and improved relationships, improved job satisfaction and retention, and improved career development. And then there's also obviously this idea of being a little bit more adaptable, right? If someone can actually solve their own problems, the whole organization can be more agile and adaptable. So I just wanted to mention the GROW framework. I'm not going to be able to have time to get into each item specifically, but the GROW model is really a way to walk a coachee through a process. The first step is, helping them to identify their goal, then helping them and really just asking the questions to get them to sort of say what the current reality is. Thirdly, to identify for the coachee, to identify what are the potential options, what are the potential next steps. And then finally, the coachee, choosing their way forward. What are those steps that they're going to take? And really the coach, should really have very little input into each of these questions or the answers to these questions until maybe the very end, when you can ask a question like, do you have any questions for me, or would you like my thoughts or my advice? So that's the GROW model. I wanted to talk a little bit about our other session, which was really focused on recognition. And so how do we recognize folks in a way that's meaningful, authentic, and that can actually improve well-being and engagement? And so my first point here is that please don't make more awards. This is not about, giving people trophies or, giving people even bonuses necessarily. But instead, it's really about aligning the values, pride, recognition, and engagement all together. And what I mean by that is the first step is to really, as a leader, recognize what you value. What do you value in your team? What are the sort of values of your unit, of your service? What's most important to you? Once you have that really settled, then you can begin to understand what ways people actually might express those values and what ways you might actually be able to be proud of people, right? So when people do things that mirror the values that you have, you'll start to feel proud of them. And once you feel proud, you'll be able to recognize them for those behaviors and actions that they've taken that align with the values. And then once you recognize them, the idea is that they'll become more engaged because now they know, oh, my leader really appreciates when I do X. So I think I'm going to do X more because they've, said something about it. And what's nice about that is it helps to redefine and realign the values of the team. And so I think this is sort of a core idea when thinking about recognition, right? We often give people recognition because they, had a paper published or, things that tend to be not necessarily behaviors that you're visually seeing. And so this might give an opportunity to do different kinds of praise. And again, just to give a sense of what we're really talking about with appreciation and recognition, it's really just like giving feedback. You want to make it specific. You want to make it based on observable behaviors and performance. You want to make it timely, right? Right around the time when you see the action actually happening. Should be relevant and should be sincere. How do you do this? You make it a habit. You create cues or you schedule time for yourself to thank people. You get help from others and you be present, right? If you're a leader that never actually gets to witness what your team is doing, it's going to be really hard to actually thank them or appreciate them for that. And so at during our workshop, we talk about these 3 levels of praise: surface praise, specific praise, and attribute praise. And just to give you some quick examples of what I mean, surface praise is that like general statement: great job, you did a wonderful job today, thank you so much, right? It's nice, it makes you feel good, but it doesn't really dig deep. It doesn't really give you a sense of why someone's thanking you or what you did that was so great. Level 2 is praise on a behavior, right? So what did you do that was really great? Your presentation was really very organized, clear, and to the point. So now I know, okay, they really liked a particular behavior that I did. But level 3 is even above and beyond that, right? It's really an inclusion of level 2 and also a nod to what type of attribute that person has that you think sort of contributed to their behavior, right? So for example, your compassion, you showed compassion and patience in a calming tone and time you took to speak to that client, right? So really identifying some attributes of the person that had those behaviors. So just a very quick summary on what we found with our workshops. So far, we've trained over 200 faculty, nursing, and advanced practitioner leaders. Of those, 23 were department chairs, 15 institute directors, some CEOs and CMOs. We had about 62 people complete the post survey. And what we found was that pretty much almost everyone that completed the workshop agreed that their knowledge or skills were increased and that others would benefit from their workshops. The GROW model was cited as the thing that was most likely to be used, as well as leveling up praise. And what we found was that we did a pre-post and humble inquiry, the GROW model, and core values. People reported an increase in their knowledge and skills significantly, and then the likelihood to use the tools increased for all the coaching skills and for level 3 praise. So the final section I wanted to talk about is informing and including. We haven't done a workshop on this yet, although it's probably coming, but there are a couple of other interventions that we've tried to really make sure that leaders have the tools to inform and include their staff. So the first thing is just understanding some basic principles of communication, right? None of this is going to be surprising to anybody, and I put some examples of things that we do. So first of all, to deliver current, reliable, and reassuring messages, one of the things that our institution did during COVID, and I'm sure many others have done too, is weekly broadcasts from our CMO that include lots of information about COVID, but also about staff and resources for mental health and burnout related issues. Being authentic, honest, and compassionate with the communication, anticipating and addressing stresses and concerns, right? When something is about to happen, or people are getting nervous about something, it's important to make sure that that's in the messaging. Making the messaging frequent and multimodal, right? Not everyone reads emails, but what are some other ways you can reach people? Social media, screensavers, flyers. And probably one of the most important things is to think about two-way communication opportunities, right? So we've had town halls here, which have been taken up actually quite well, and lots of people ask questions during those town halls, but that probably doesn't reach everybody, right? So what are some other ways that we can get feedback? Surveys are really important, as well as even some focus groups. Communications and team trainings in and of themselves have been shown to improve well-beings of teams. And then finally, rounding. And this is the next slide I'm going to show you. So one of the things that we did during COVID was we created a staff guide for leaders. And this was really to help our leaders figure out sort of how they can support their staff. This was based on the Hartford Healthcare Leadership Rounding and also a paper by Shanna Phelps, Dr. Rip, and Dr. Trockle. And I'm not going to go into this in any more detail, but this was something that was available to all of our leaders and really emphasized the idea of frontline rounding, so really being present. And a lot of our nursing and hospital leadership staff did do this and went to all the units during some of the most challenging times during COVID. The final thing I wanted to mention is, how do we think about empowering our staff, our healthcare workers, to feel like they have control over their environment? One of the things that we think is a driver of burnout is a sense of lack of control, right? Not being able to, make your schedule, not being able to choose what you're doing from minute to minute, right? So how do we empower folks to do that? One way is through quality improvement. And Steve Swenson and many others have created this listen, act, develop model, which basically can be paired up with our quality improvement model. The idea is that our leaders should actively seek feedback from teams. They should empower those teams to develop solutions, and that really is where the PDSA cycle and QI comes in. And then not only that, but there should be development, and not just development of the projects, but development of those leaders who are actually working in the QI and well-being space, right? So how do we make sure those leaders have the tools to do QI and well-being work, making sure they get training, making sure they have coaches. So there's lots of opportunity here to really integrate the idea of quality improvement, safety culture, and well-being culture. And we certainly know that a lot of the goals are aligned, right? In quality improvement, we're looking to decrease waste, we're looking to decrease burden, and thereby, hopefully decreasing decreasing the burnout of staff and physicians. The final thing that I really wanted to mention was another way that we have looked to empower folks is by creating well-being champions. And we have well-being champions. Actually, I'll go to my next slide just to give you a sense. We have well-being champions or advisors really at every constituent group in our institution. I shouldn't say every, but certainly within our school and working towards the hospital. So you can see here that we have well-being champions for our GME group, for our faculty group. We have over 30 faculty well-being champions. And then we have wellness advisors for our undergraduate and graduate school. And more recently, we developed site well-being champions. So within Mount Sinai, we have 8 hospital sites, and we wanted to make sure that each hospital had someone who could really be checking up on the well-being of the staff and coming up with solutions to potentially improve the well-being there. And so we really follow the idea of the listen, act, develop model through our faculty and other well-being champions, right? So the purpose is to gather data and feedback on well-being, burnout, and satisfaction, then to prioritize problems, right? This is the act part. Prioritize problems and brainstorm solutions with the teams and their leaders, and then develop a departmental or unit or service plan to address well-being. And these are annual plans, and they come up with all sorts of really great ideas and interventions to really systemically, as Dr. West was saying, improve the well-being in their units. And just to be very clear about that, most of the time, these interventions are not, bring in yoga or bring in mindfulness. Most of the time, they're very systemic, efficiency-focused, practice-focused interventions. And some other things in terms of developing those well-being champions, we make sure that they have a curriculum so that they have a good knowledge base in burnout. They are a resource to effectively communicate and share well-being related data and resources to their departments and units. And they get to meet with each other monthly to discuss challenges and share best practices with their peers. So just in summary, we know that leaders' behaviors have an impact on their team members' well-being, and leaders can potentially improve the well-being of their teams by practicing the following: exercising humble inquiry, actively listening, utilizing the GROW model to facilitate goal achievement, aligning values and showing pride, recognizing team members through specific praise, communicating authentically and regularly, and empowering staff to take over control over their work environment. And just to reiterate some of what Dr. West said, for an organization, it's necessary but not sufficient to teach skills and provide resources, but it has to be an organizational priority. And well-being leads need to be at the table, right? Not just one table. They need to be at all the tables. You need to have well-being representatives infiltrating every space in the organization in order to really push through the agenda of keeping our healthcare workers well and trying as much as possible to prevent burnout and other stress-related and even potentially mental health issues. So, final slide is that, I think it's really important as leaders in any profession that our job is really in the service of those we lead, right? So in order to rise us up as organizations or as healthcare in general, we must lift up others. And often those others are those that we are leading. So thank you everyone for listening. This is my email and my Twitter, and I'm going to stop sharing and happy to take questions.
Thank you both, Doctors West and Peccoralo. This is, again, an incredibly information-packed day filled with lots of great insight, information, and strategies that I hope folks are walking away with. Again, just a reminder who I am. I'm Brandy Clark, and I'm a project director for the Mid-America MHTTC, and I'm going to help moderate a couple of our questions here for the end of the day. And so I've got a question, I think one each for both of you. We'll see how much time we have left today. Dr. West, there were some questions. You provided some very interesting data and information about just note writing in general. And as a clinician myself, I know that this documentation, that the burden that places on all of us. So there were some questions that came in about the impacts of litigation and billing, and what that does to length of documentation and how that has an impact on burnout. Could you speak to those two areas in terms of their impact, litigation and insurance?
Yeah, absolutely. And so this is one of the factors that's been held up as more of an issue in the US healthcare system than in a lot of other systems around the country. The perceived concern about sort of defensive note writing to protect against potential litigation far exceeds the actual risk from note writing. But that's small solace if you're ever in a position where you've actually had litigation filed against you. So I don't want to minimize that concern. It certainly has an impact. And I do think that this is an example of national policy level protections that need to be in place with advocacy from our largest healthcare systems and societies to help improve these issues. From an insurance billing standpoint, I actually have some positive news to share on that one. I think many of us in practice, especially in primary care and general medical areas, have experienced. Yes, documentation for insurance requirements has been a major burden in these systems. And those of us who actually use the notes and patients who read the notes recognize that these documentation burdens actually diminish the usefulness of our notes in many situations. They make the core content of that note almost impossible to find. With revised E&M coding that many of you may be familiar with, the documentation burdens have been markedly reduced. There's still work to be done, but I can tell you in my own practice, it's been a breath of fresh air in the last 6 months to be able to, assert that I spent a certain amount of time and that my validation of the issues is sufficient without needing to basically write through every single decision point that happened during that visit, basically relive the visit with the patient. So we're like doing everything in duplicate, which is how it used to feel. And being able to also get credit for the time outside of face-to-face interactions where we're thinking about the orders or the test results on behalf of our patients, and having that, as long as it's in the same day, count toward our insurance billing generation. I think are steps in the right direction. And it's important to note that those steps have happened, at least in part, because of advocacy efforts around the country. And there's ample room for criticism of some of our groups around the country, including the American Medical Association, but I think we need to give credit where it's due. And that's, people like Chris Sinsky, who's the vice president for professional satisfaction for the AMA, has been at the table with JCO and CMS and the insurance companies to impress upon them how they're actually shooting themselves in the foot in the long run with these overly burdensome requirements that actually aren't helping patients. And we are seeing some signs of progress. So, there's still work to be done, but there is absolutely hope on the horizon.
That's fantastic news to hear. I know for all of us who are note writers, that we could use that grain of hopes. And so, Dr. Peccoralo, another question that I have for you that's come up from the audience is related to, you talked a lot about leadership and the role that leadership plays. And knowing that when you have a diverse workforce, not everybody responds in the same way to your leadership style. And so one of the questions relates to how to address or work with offices who maybe have a negative impression of agency leadership when that's not necessarily a shared impression by all within your team.
I mean, my feeling is just to go there, right? I mean, you can't fix a relationship if the two groups are deciding that they've made judgments upon each other, right? So there's work to be done, and you may need to adjust your leadership style based on the people that you are leading. So it may be that certain groups really like a certain thing and it's working great, but if you're overseeing 16 offices, right, there's going to be a couple that aren't going to jive with your other the other ones that are working. So I mean, my suggestion is just to use some of these techniques to go in there, use humble inquiry, start by being use your humility, right, to say, look, I understand this doesn't seem to be working. How are you guys feeling? What are some of the issues that you're facing? It's got to be authentic, so you can't just go in there and, wave it away. But if people are willing to take a little extra time, I think it could go a long way.
Excellent. Thank you for that. I think we could have lots of conversation about information presented today, but unfortunately we're reaching our limits. I thank you guys though for sharing your contact information. And I want to remind folks who are engaged with us today that all of our slides and presentations, they're recorded and they're going to be made available to everybody through our MHTT website after this presentation. So you will have access to those. But we're not done with these conversations, although we're wrapping up today. We do have another day yet tomorrow, and we're pretty excited about that because it will give us an opportunity, one, for more discussion. Some with our presenters today, Dr. Peccoralo, I know you'll be joining us tomorrow, as well as Dr. Stewart, who presented earlier today. Along with some new members, we will be having Drs. Carol Bernstein, Andrew McLean, and Steve Wengel join our panel that will be moderated by Dr. Jeffrey Gold. And so that should be a great discussion on national perspectives for improving organizational risk responses to well-being for our healthcare workforce. But in addition to that, we have the opportunity to engage in some real deeper dives and some strategic planning around this content that we're learning about. And doing so through some interaction around a new tool that's being developed on an organizational well-being inventory. And that work will be done in some teamlets throughout the day tomorrow. So we hope to see as many of you back again here tomorrow to join us for those conversations. Just as a reminder, you should have 2 links for tomorrow, the presentation for the panel, and then a link for the remainder of the day for those strategic planning sessions. Before we leave, we do ask that you would do one thing for us, and that would be to complete an evaluation form, just getting your perspective on what you thought of today's session. These evaluations are critically important to our funding and for our ability to continue to provide these trainings free of service to you all. So please, when you receive that link for the survey, please complete that for us because your feedback is incredibly important to us. And I believe, do we have the link to our survey? Here we go. Thank you. Here on this QR code, or you can complete this link, and I believe we'll post that in the chat for you as well so that you have options of completing it that way. Yes, it's posted there. Again, like I said, we do value this feedback pretty highly. So please take a moment to fill that out for us. And with that, we will wrap up today's session. And thank you again to our presenters for all of the information that you shared. I know it's been echoed in our chat box many times over that this has been incredibly valuable information today. I also want to thank our audience for all of your engagement, for your posts, for your questions, and for taking the time to stay with us today. And with that, what I will say to you is be well, and we hope to see you again tomorrow.